Hi, this is E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. Joining me is Dr. Gerard Henry, who is going to share with us a presentation that will be made virtually at the AUA meeting on something unique he is doing, and that's using next-gen sequencing, identifying biofilms and antimicrobial sensitivities and resistance in penile prosthesis. Gerard is one of the top implanters in the world. He does about 200 penile prosthesis a year, trained at Duke, and then worked with Steve Wilson for 3 years in prosthesis, and has a special interest in not only in this, but understanding the etiology of infection. So, Gerard, take it away.
Thank you very much, Dr. Crawford. We're going to present data comparing traditional cultures versus next-gen sequencing. Just remember that you get your PCR data if you have the machine at your facility within an hour or two. That will give you data on major pathogens. So here we go. Previous studies have shown traditional culture methods have been used to identify bacteria and fungus at removal replacement of penile implants. Next-gen sequencing appears to be considered the gold standard in other medical specialties, especially wound healing. The purpose of the study was to compare biofilm compositions and antimicrobial sensitivities at penile prosthesis removal replacement, comparing traditional cultures versus this next-gen DNA sequencing. Methods. 2 cultures were taken, basically specimens, I shouldn't say cultures anymore. 2 specimens were taken, 1 sent for traditional culturing and then 1 sent for next-generation sequencing. Results. 101 patients had both traditional and next-gen sequencing results to compare. Some of the bacteria identified using both methods were known prosthetic pathogens. However, the next-generation sequencing produced more isolates than traditional culture at a very high significant level. In addition, next-gen sequencing gave more data on antimicrobial resistance genes than traditional culture methods did. Here's the data. Next-gen sequencing showed an average of 9 specimens per sample sent. Again, this was statistically significantly more than traditional culture. Here is abundance. One of my favorite things about NGS, next-gen sequencing, is abundance. And then percentage of samples occurring here. Here's E. coli as an outlier, and here's one that I was not aware of, and I have used on my patients who had an infection. One of my patients had an infection. You understand this is the number 2 abundance bacteria shown by NGS. I didn't even know this existed by traditional cultures. When this patient had an infection, he had a negative traditional culture, but had Actinobacter as his bacteria causing the infection. This is what I mean by we will be rewriting what the known pathogens are from staph to other bacteria. It will be changing our treatment most likely. So in conclusions, next generation sequencing of DNA appears to be beneficial in its more thorough analysis of biofilm on penile implants in vivo, that's in the patient, and appears to be more sensitive, gives relative abundance, which I think is very important so you know which bacteria is causing the infection, and more antibiotic data than traditional culture methods. The future of NGS and prosthetics. This has already been well established in orthopedic joint infection cases. Currently submitting 2 articles, one looking at how NGS improves infectious isolates better than traditional cultures, and the other, the gold standard data you just saw. We are also planning on a prospective randomized multi-centered study, currently 17 centers. We're going to do a head-to-head trial for the first time ever, comparing NGS versus traditional cultures and how the patient is treated. Thank you for listening. NGS is currently the gold standard in other medical specialties. NGS appears to be better than traditional cultures in detecting isolates in prosthetic urology. And I'm excited about the future head-to-head prospective randomized study comparing the two methods and seeing which one has better clinical data. My hypothesis is that NGS will save more implants than traditional cultures. Thank you for listening. Dr. Crawford?
Thank you, Dr. Henry, for sharing your information with us in that presentation. I understand that that a couple of the presentations with next-gen sequencing have already won some awards at meetings. Is that right?
Yes, sir. 2 national meetings, one best clinical abstract.
Oh, great. Well,
Basically
congratulations.
Thank you.
This is what we have been doing for the past 100 years with our standard culture and sensitivities has been okay, but I think it's in some areas is becoming very archaic and outmoded. And what you're describing makes a lot of sense. And my understanding is, and you mentioned this, that in orthopedics there's and also ENT, there's a tremendous interest in this and identifying pathogens. Is that your experience too, or what you've learned talking to your colleagues?
Yes, sir. Orthopedics is actually way ahead of urology in the next-gen sequencing data. They are already having multi-center studies using it to determine what is exactly causing the infections. Like I said during my presentation, not only is it giving us new bacteria that we didn't even know existed in implant infections, it's telling us what exactly is causing the infection and hopefully how to treat it better in terms of the antibiotic resistance genes.
I applaud you for setting up this prospective study. We all know that that's what it takes to convince people. That my guess is that this is going to be a very positive study. When are you going to launch this? I know with all the COVID stuff going on, there's been a delays, but do you see this starting pretty soon?
I do. In terms of the protocol is written, I've had a medical editor go over it and help me, and I've sent it to several colleagues for critique, and I hopefully will be rolling it out maybe by the end of the summer. I mean, it's already written. I just need, when it comes to prospective studies, as you know, you'd like to have all the I's dotted and the T's crossed and try to capture as much as you can up front, because you always feel like you wish you'd captured more after the study's over.
Right. Well, that's great. Is there anything else you want to add before we sign off?
No, sir. Just thank you for allowing me to present, and I hopefully we'll be giving you more data in the future.
Right. Thanks. Thanks, Dr. Henry. We appreciate it and look forward to your clinical trial. We'll certainly make it known to our people that listen and view our website, and we'll hopefully talk to you again soon about some more data. Thanks a lot.
Thank you, sir.